Welcome to the Doctor's Corner with Dr. Kline and Janelle Elgaway. And now, your host, Dr. Kline and Janelle Elgaway.
Good evening and welcome to the Doctor's Corner on CAW 360 Network. I'm your host, Janelle Elgaway, and co-host Dr. Kline. Welcome, Dr. Kline. Okay, I know he's there. All right, so tonight's topic is on the 90 MME cutoff. There are two ways to listen into tonight's program through our website, www.cawnation.com, or our YouTube channel, The Doctor's Corner. Dr. Kline loves to hear from you and answer all your questions from our mailbag. If you have future mailbag questions, please email them to Janelle, Jonelle, .Elgaway, ELGAWAY, at caw360.com. If anyone would like to call in with a question this evening, you can do so at 415-915-2291. Before we start, Dr. Kline, is there anything newsworthy that occurred in the last week or few weeks that you would like to share with us?
Yes, the 700th opioid summit has taken place in the U.S. government. It seems that the more you talk about it, the closer you get to a solution. But if you're getting close to a solution, why are you talking about it so much? So now this agency is HHS, which is Health and Human Services. This is the grandparent of all the medical health-related agency. This used to be called the Public Health Agency, and now it's the Health and Human Services. Most states have these as well. So we had summits at the FDA, and the president had a summit, and then there were multiple summits between multiple agencies, et cetera, et cetera. It seems that all this talk would lead to a conclusion, which I have yet to see. So HHS has issued a 100-page report on the opioid crisis, similar to the 100-page reports at the VA and the 100-page reports by other opioid summits. The conclusions are expressed in a lot of double talk. Whenever medical people don't know what's going on, they say, what we need is the multiple disciplinary process. Always sounds good. What do you mean by multidisciplinary? Well, let's see, the pharmacy, let's see, what else? The doctors and the physical therapists and the social workers and the psychologists that think that if just with mindfulness you can get rid of your pain, and we're all going to get together and we're going to have this multidisciplinary approach. And there's a lot of other adjectives they put in there that lead one to believe they don't know what they're talking about. So this is a 100-page report. Now, really, a report on opioids should be about 2 pages. One, we only have one drug to treat pain, and that are opiates. Opiates can cause the side effect of addiction in 0.5%, similar to the side effects of Humira, which is a drug for arthritis, in which you can suppress your immune system and die, or you can get cancer. So all drugs have problems. And one of the problems that is being addressed by the HHS is the addiction problem. They keep focusing on addiction. Now, they do pay lip service to the fact that we do have people out there sick, but then you see the big 3-letter word, but. Oh, we have a lot of pain patients out there, but we got to balance that with the opioid crisis. Now, I'm not quite sure what they mean by balance because they don't actually say what it means to balance. The problem is they don't know what they're talking about because nobody understands addiction, because nobody has really talked to people with addiction disease. If you want to find out about diseases, you talk to the patients that have them. But these opioid commissions, usually with gigantic circular tables, sometimes with 40 or 50 participants, there's never anybody there who has the disease. So this is like having a summit about how to treat diabetes, but you don't invite any people with diabetes. Now, they tried to invite a few doctors. That was good. That's an improvement, because the CDC regulations, basically, they invited nobody outside of their small group who knew anything about addiction. The good news is that this is a draft, and they're going to allow people to make comments. So that's good. So we can put in comments. They do read them. One of the comments that I'm putting in is that we need a national definition of palliative care. It's in all the state documents. It's exempted by the CDC guidelines. Palliative care is exempted, is protected by law, really. In other words, you can have the state make some rules about cutting down on the opiates, which we all know doesn't work, but they do it anyway. And then they exempt palliative care, and then they didn't define it. Well, that's kind of sophomoric.
So how come a definition is so important?
Well, because when patients, I'm finding, go see their doctors, and they say, well, I have palliative care, and the doctor goes, what's that? Well, it's in the law that I'm exempted. Oh, I don't believe that. And don't you have to be dying and have a special program? So I've written a little piece that we're going to be putting on Medium that explains this is really pretty simple. You have a patient who has a disease that has no cure. And if it doesn't have a cure, then you take care of the symptoms. Could be pain, vomiting, diarrhea, terrible rash, coughing, whatever. But there's no definition, so the doctors don't know what to do. It'd be like saying, we're going to arrest all funny-looking people, and then you don't describe what funny-looking people are. So if the federal government could establish a simple diagnosis criteria, and there are really only two, then doctors would say, okay, this is a disease, and here are the criteria of the disease, like any other disease. Palliative care does have a ICD-10 code, which are the codes we use for diagnosing various diseases. Z, as in zebra, 51.5. So the code is there, the laws are there, but doctors don't have a definition of exactly who people are. And it's got nothing to do with your lifespan. So there's a little piece I've written, hopefully I'll have it out next week, that, presents a whole bunch of definitions, one from the UN, one from NIH, one from England, I think, blah, blah. There's several in there. None of them say anything about lifespan. And they have basically the two criteria. So once we have that, then the doctor can say, oh, you are palliative care, therefore you are protected by our state laws from reductions. I mean, this is real important. If they would adopt a good definition of palliative care that people could understand and did not involve lifespan and death, this would free almost all the patients in the United States who have been horribly, horribly damaged by people like this prop organization that I'll discuss later. Horrible. This is the worst medical tragedy in the history of the United States and perhaps in the world, because there are 6 to 7 million people seriously harmed because doctors forced them off successful pain medication regimens that were working just fine because somebody told them to do it. Now, there's been a lot of that. Go ahead.
Oh, what's the code for palliative care again?
It's Z as in zebra, 51.5. So it's a recognized diagnosis in the big book that we use of diagnoses. So that's nice. It's not some mystical mystery concept. It's a real thing. So
I think that will be wonderful. Yeah. I know a few people have mentioned they're concerned if is there going to be like a list of all the different issues, health issues and stuff like that for palliative care, or is it just going to be the definition? Because I know people are concerned that they're going to be left out.
Well, no, the definition is simple enough to include everyone. If you've got a disease that can't be treated, and that's everybody, right? And it's producing symptoms that, if relieved, would improve the quality of your life, that's everybody. So unless they fiddle with it and do something dumb, like saying, well, this is only at the end of life, everybody should be covered. And I am personally developing with my associate David Williams, who helps me with these forms, a little wallet-sized card. Diagnosing palliative care in the office is like diagnosing an earache, or diagnosing a congestive heart failure, or diagnosing pneumonia. It's the same process. You examine somebody, the doctor in the office says, okay, you've got palliative care, Z515, also you've got an earache, Q9178. They're just diagnoses. And once you make the diagnosis, and only doctors, by the way, can make diagnoses, or licensed healthcare people like nurse practitioners and assistants, physician assistants. So once you establish a diagnosis, then you can fill out this little card and give it to people. So when they give you a hard time at the pharmacy, you can say, I'm protected by law in this state from reductions. Here's my card. Why are you doing this? Or we hear every day. Go ahead.
I was just thinking, what about also, because a lot of people are on disability, on SSDI, maybe it would come with your Social Security disability card or something.
That would be great, yes. But it basically has to be established by a physician, and just an office physician is fine. And once you do that, and you have somebody who has in chronic care, the doctors can then use the chronic care management codes and make more money because they spend more time. And there's special codes now for if I see a patient and they leave and then they've got a problem 3 days later, I can bill for that. Previously, you could not. You have to have the patient in the office to bill. So doctors, it's so simple that because of the fear of addiction phobia, everybody's going, what? What's that? Palliative care? I don't think so. They'll still come and arrest me, won't they? No, they're not going to come and arrest you. And if you have the law behind you, if it says, that you have to, let's say, treat below 90 milligrams, except for palliative care, well, guess what? If you have palliative care, you can get any dose you want. But people are going to have to force the issue. And they see that's why we need this national definition first. Because nobody goes, no, I can't treat something I don't know what it is. It's all different in the books. So we're working hard on that, trying to get that put through in this latest opioid summit. I mean, reading these reports, it's almost ludicrous. You can tell they don't know what they're doing. And you can tell they're so afraid to step on anti-opioid toes that they use all this odd language, of trying to soft pedal.
So
there's
what are
one
they filling all of these things with? I mean, you said that there are over 100 pages every time they, put something out. What are they even filling it up with?
That's a real good question, because I've become so sick and tired of these things. They're not reading them anymore. But what they do is they start off real primitive. Oh, opioids are they grow on a plant, and then they start filling it in, and then they start quoting a lot of articles that were quoted in this first petition to the federal government, all of which are false and poorly documented. And I think they are so bad that it almost looks like a put-up job. Now, I'm going to say that in public. And if people want to argue with that statement, they can certainly get hold of me. But that is my professional opinion after reading all the articles that went into this petition in 2012 to the federal government to limit the use of opiates. They make these absurd statements, which we can go into in a minute when we start talking about the 90 milligram cutoff. But if we have questions or callers, somebody wants some of my jellies and jams.
I was going to take a few questions from our mailbag.
Okay.
Somebody wanted to know, what is drug-seeking behavior nowadays? Is there any standard, or is it subjective by medical professionals, just as they claim our perception of pain is subjective?
It's a created term to fit into the fear of addiction phobia. It means you're looking for drugs. But you see, we have split addiction into two kinds. Type 1 addiction, where you do not have a withdrawal and you can stop. And that's marijuana, cocaine, amphetamines, and most people who drink alcohol to excess. That's type 1 addiction. And in type 1 addiction, you can stop whenever you wish, and you need therapy sometimes. And you still have an addiction because you may be taking too much of these things and ruining your life. And type 2 addiction, as we brought up, is hardwired brain addiction. That's opiate addiction, cigarettes and nicotine, and 5% of alcohol users who develop the DTs. So we have to look at the fact that how many type 2 opioid addicted people are there? There's 1 million. And how many people have to take opiate pain medicine for their rare diseases like Ehlers-Danlos and central regional pain syndrome and trigeminal neuralgia and adhesive arachnoiditis and failed vertebral surgeries, et cetera, et cetera. There's 10 times more people taking medicine for disease. So now, who is drug seeking? So if you go to a doctor and you need to have 100 milligrams a day of brand X to relieve your pain, and your doctor gives you 50, that person may start to look for other sources of medicine for their pain. Why not? We are under-treating pain in the United States on purpose, when we don't need to do that, and there's no medical reason not to do that other than the hysteria of these people, the prop organization. So drug seeking is a relative term. The real drug seeking is only with type 2 hardwired addictions, and that includes cigarettes. So have you ever seen anybody or been a smoker and you were out of cigarettes and you started going through the butts in the cans outside the restaurant? Mm-hmm. That's called intense seeking. Now, people with type 2 opiate addiction, where there's been hardwired brain triggering of addiction, you have intense seeking of substance without regard for consequence. That's what a type 2 addict is, whether it be nicotine or opiates or the 5% of people with receptor disease, alcoholism. So you see, by using the word drug seeker, that's a pejorative term that indicates you are an intense drug seeker. If you're just looking to buy some marijuana Are you a drug seeker? It depends on the definition of drug. If a person smokes marijuana and nothing happens, are they abusing the drug? Misusing the drug? Well, the United States government says you're misusing and abusing, and therefore you're a drug seeker, and therefore you're an addict, and we can just pump up the number of addicts that way by labeling the disease incorrectly. Drug seekers traditionally were addicts, type 2 opiate addicts, who went to 2 or 3 doctors to see if they could get 2 or 3 prescriptions to take as they need for their addiction. So they became drug seekers. Actually, drug seekers, that is, people with 2 doctors prescribing, 60% of those are, guess what? Painful disease patients who are undertreated. And they're doing anything they can to relieve their pain. So they are drug seeking, but for medical reasons. 60%. Last year in North Carolina, they caught, guess how many drug seekers with their great computerized dragnet? 5 people. 5. And we don't know whether 2 or 3 of those were actually folks trying to get additional medicine for their painful disease. So you see, the failure to separate the 2 addictions and the failure to separate painful disease is just not clear in everybody's mind, because people are so frightened they are going to become addicted. Their mother's going to become addicted, or worse, their children are going to become addicted. People can become addicted from opiates. It's a side effect, like death from Humira. But it's still a side effect that can be managed. You know, we have blown this kernel of truth way, way out of proportion, because we assume, as they did during the witch trials in 1690, that anybody could become possessed. And guess what? People now think anybody can become addicted. All you got to do is get this opiate in your mouth, and you are now at risk. But the truth that's being hidden is that, yes, you can trigger an addiction in 1 in 300 people. And if you do, it can be treated. And that's no reason not to take the drug for the other 995 people who will not have the side effect. Same with Humira. You know, 1 person in 1,000 may die from an infection, but that doesn't mean the other 999 people can't take that risk and on their own and make their own decision. We do not allow people on opiates because they're radioactive, they're dangerous, immoral, cause crime, and worse, vice. Vice is the key. It's always tied up with sexual crimes, miscegenation, xenophobia, all woven into the little pill that's held responsible. And it's not true. So we can avoid the horrors of addiction by everybody learning that in adults, there's about 1 person per 1,000 that has escaped triggering, who has the genes for the disease. It will be triggered by the very first pill. I reviewed interviews that I've had with about 15 people with heroin addiction, and they all say it started immediately with the very first pill. That doesn't sound like addiction where you're taking a whole bunch, like stoners, you know, for marijuana. It sounds like there's something different going on, and there is. It's a real disease, and it's being triggered by the very first exposure to opiates. That's why you hear the story of the poor kid who, you know, gets a Vicodin prescription and then a month later turns up dead in the streets. That's because of ignorance Had the doctor said, have you ever had an opiate before? And if you haven't, and you go on this magic carpet ride, I want you to call me right away because you've got addiction disease. Pretty much the same as, if you start urinating all the time, you may have diabetes. You need to let me know about it. So because of this ignorance of thinking that everyone can be possessed by the devil, everyone can become a dope fiend like we see in the movies, then this is going to continue. Once people realize that, yes, there are facts, but they are a lot less than people know because we haven't been given the facts, and that's why I'm here. My job is to give facts to people. I don't profess political ambitions or political positions. It's just providing facts to people. Whatever people do with the facts is up to them. But we have it wrong. There are 40,000 people dying every year of overdoses, and they're all street addicts. And guess how many people die from doctor office prescriptions? 500.
Right.
Okay, so we're applying all this overdose information to prevent 500 people from dying versus 40,000 people that the CDC never bothered to mention were all street addict overdose deaths. So
now, how come that number 500 isn't being talked about more? Because I know after we spoke about it 2 shows ago, when you realized this and talked about it on air, I got some pushback saying, "Oh, that doesn't say it in the." Did you find that in the CDC guidelines? Because
no, you have to read the articles in the CDC guidelines and draw your own conclusions, which I'm going to be writing up and putting on Medium as soon as I can get up ahead of steam here and do it. But there are 5 articles that are used in the prop petition to the CDC. To the FDA, and in the FDA, there's 5 articles, and lo and behold, they all say the same thing. Office overdose deaths from prescriptions are almost non-existent. And they all said the same thing. Curiously, they were using those papers, including this one to the FDA, to claim that high doses of opiates cause more deaths. Well, how do you find that out? Because their population of street addicts, you can't really do studies on those folks. So they started pulling these pharmacy records and drew these very false conclusions, and based on very tiny numbers that any science review board would immediately reject all these. You can't make statements like that. One of the studies said that there were more deaths over 90 milligrams, and when you added up the numbers, it was actually the reverse. The FDA caught on to that too. So a lot of the stuff that's surrounds the 90 milligram cutoff, which implies that these drugs are bad and need to be limited, is basically false. False to the degree that it's dubious data and dubious conclusions. So
we have a few callers. I'm going to take them if you don't mind.
Sure.
Caller from area code 303. What is your name and what's your question for Dr. Kline?
My name is Patty. Love it in the chat room.
Hi, Patty.
Hi, Dr. Kline and Janelle. You guys are my heroes. I just want to let you know that. I finally got my migraine down from a jackhammer and limited vision to dull sudden vision. On addiction, Dr. Kline, I wanted to ask you something, the skeletons of it. You explained this somewhere in July or August, so I'm going to spit it back out because I want to make sure I understood it.
Mm-hmm.
It's a lock and key mu receptor, so when an addict takes, say, the first OxyContin, it gets absorbed in his brain, the mu receptor opens up and stays open.
Mm-hmm.
But when a chronic pain patient takes it, okay, and then it gets saturated, the mu receptor opens up, and when it reaches peak saturation, it closes. Is that correct?
That's correct. What's actually happening to the mu receptor is that through at least 18 errors in the genetic makeup, it's getting bad instructions from the genes that control the structure and creation of these little receptors. So now you put an opiate into the receptor, it goes nuts. So it doesn't respond correctly. So those 18 genetic errors or polymorphisms, the geneticists call it, are all getting together to make the receptor not respond correctly. You see, 95.5% of people have normal receptors. 5% have inherited deficits that make the receptor misbehave. So the receptor may look similar. It's actually a physical shape. Picture a little a cup or something that the Jell-O is going to fit in. It looks the same.
So it's really only.
Yeah, it's
only 4 in 1,000 that become addicted. Really.
4 in 1,000 have the gene, and
gotcha.
and this is. If you take, there's 1 million heroin addicts in the United States, divide that by 320 million, or even correcting it down, guess what? 4 per 1,000.
Wow.
So we're 200,000 addicts back in 1925. And if you divide it by the population at that time, guess what? 4 people per 1,000. Now that tells you that it cannot be environmental. Because with all these drugs we feckless doctors are prescribing, like water, we should have a lot more addicts than we have. Now, the number of addicts is determined by the federal government, the Substance Abuse and Mental Health Agency. Only in the United States would they have a federal agency getting $3 billion a year for substance abuse. Abuse is a moralistic term anyway. We doctors, the good doctors, don't use that. If somebody's taking too much, then you say they're taking too much and it's causing their life to be wrecked. But you don't use the word abuse or misuse. That implies that somebody is making moral bad judgments. So they go out of their way.
Thank you so much.
Yeah, you're welcome. I do go on and on.
Sorry, honey. I didn't mean to cut you off, sweetheart.
That's all right.
Thank you so much. I appreciate you guys more than I can even say. All right, I'm going to get up so other people can call. Thank you so much, Dr. Kline and Janelle.
All right. Catch you later.
Caller from area code 212. What is your name and what's your question?
Hi, it's Julie from New York. Hello, Janelle. Hello, Dr. Kline.
Hello.
I was just listening to you that these documents, there's so many of them. I have read the Human Rights Report, and I read the footnotes, and now I'm going through the footnotes of the HHS draft. There's 446 footnotes in it.
Makes it sound real professional.
I'm only up to 117. Smoking guns. Nobody knows what they're talking about. It's just academia regurgitation over and over again. People who have no idea what about complex bodily diseases. It is frightening. And I can't expect everyone to go through this, so I'm going through it and documenting it. But they knew it was illicit fentanyl the whole time before the guidelines. I found a few documents about that. The CDC knew. And also, we're being academia'd to death. Everyone wants to be published. And how could something have 446 footnotes? How could one document have that many?
Well, that prevents anybody from reading it.
Well, it's all referenced from past fallacies. So the whole HHS draft is based on references from 2006, from PROP. I've found so much of it. And nothing is new. They're not even looking towards anything new. They're just regurgitating the past. Yep. And, you're right. They do not know. It's a put-up job. They don't know what they're talking about. I think the best idea, this is what I did today. I found the #1 specialist of my disease, and I'm going to ask him to write a letter to the docket explaining, because I think everyone needs to get real doctors involved in this, because these are not doctors that are dictating our pharmaceutical needs and our lives. Everyone, it's all addiction specialists, and all of them are just pushing bupe constantly. So it's tedious. It's going to take me weeks to get through this, and I'm going to get through it. But the links, and then you go from one link to the other, and it's more frightening than the one before. It's true crime, what I'm reading.
It's a real
making it up.
They're making it up, and I have a blackboard set up, and I've got CDC, the VA, and the FDA, and PROP, and I'm trying to track all the articles that are shared, and I'm getting pretty close. As you said, the critical articles for when PROP petitioned the FDA to limit the amount of. Okay, and all the references are from PROP people. Now, is that bad? It's not necessarily bad, but you have to disclose that PROP is an organization that has an extreme viewpoint. It says
more to that.
Yeah, it says right in the beginning that unfortunately many clinicians are under the false impression that chronic therapy with opiates is evidence-based treatment for chronic non-cancer pain. So what is that? They're making a statement, and there's no references. Many clinicians are under the false impression. I don't remember reading a study about that. They're just making it up.
And this is the most devious part. If you look at the address on the PROP letter, the original one, and the signatures, I'm in New York City, the epicenter where this started. It goes to Eric Schneiderman. There's so much. I don't want to be a conspiracy theorist, but the address is this one-star psych ward in Brooklyn where Kline was working. That's the original headquarters of PROP. And they did this closed-door meeting with the Department of Health. I don't understand how a one-star psych ward shrink could have gotten a closed-door meeting with the head of the Department of Health. It just doesn't make any sense. And it's such a jump. It's very hard to get meetings with these very high-level bureaucrats. And he just walked right in. And
the man is very good at what he is very, very good at what he does. Unfortunately, many clinicians are under the false impression that therapy is evidence-based. That's an interesting statement, isn't it? That's like me saying, most all doctors are idiots. I should be able to back that up, that I've done a survey and found them all to be idiots. But look how slick that is. Unfortunately, many clinicians.
Terrifying.
Julie, did you have any other questions?
Oh, no, I'm sorry. I didn't mean to rant on. I just wanted to tell Dr. Kline there's 446 footnotes.
Yeah, let me know. Report. Yeah, try to email me. Let me know what you find, because I just don't have the
Dropbox.
I just don't have
email it.
Whatever, figure out a way. Janelle can help you, but I'd like to hear what you finally discover.
Absolutely. Thank you so much for everything,
right.
Dr. Kline. Thank you, Janelle. Have a good night. Thank you.
We have a bunch of questions from YouTube. Nurse 65 wants to know, what is opioid use disorder?
It used to be at the federal substance abuse agency. It was pretty much aligned with the psychiatric definition, which is somebody using opiates when they weren't prescribed to them. So that means you're getting them illicitly. And some of those people are probably addicts and some are just goofing around. So what they did is they kind of classify them all as substance use disorder. So they're kind of taking in real addicts, junkies, into that number, but they're adding to it because a lot of people who take opiates not being prescribed are just doing it, got nothing to do with addiction. Then they did something really sneaky. They changed the definition from using opiates that are not prescribed to you to if you're receiving prescribed opiates and you take them in a way other than prescribed, you are now a substance abuse disorder.
So say if I am prescribed 90 MMEs a day and I take 120 MMEs a day?
Or even less.
Or less?
Yeah, or you're not taking it as prescribed, then they go around to people's homes and they give them $35 and they do this annual massive survey of the country, and all they do is come up with these numbers, Latino girls below 16, 5% of them smoke weed, and they just this 100 tables. But by changing the definition of substance abuse disorder, everybody thinks substance abuse disorder is addiction, and now we've got millions of people because millions of people take their prescription drugs in a way not on the bottle. I mean, I would think that would include almost everybody, because if you're taking an antidepressant and you think it's having side effects and you stop taking it for 3 days, you have now taken the drug differently than prescribed. And these surveyors, I don't know if they take that into account. They just ask them this question. They don't ask, did you take less? Or did you skip some? Or you're having a particularly bad day and you took more? And it's also real irritating to me as a physician because when you prescribe pain medicines to people and the doctor doesn't really know how much pain they're in, they have to be treated according to FDA guidelines, which is titration. So in other words, each person establishes a range of medicine. On a good day, you may take 2. On a bad day, you may take 4 or 3 or 2.5. So you see, they not only lied and really did something that's dishonest by changing the basic definition of a disease they created in the first place. They're also implying that they have the information that this particular drug group has to be given in a fixed manner. If it says 1 every 4 hours, that's what you got to take. And that's real ignorance. That's real medical ignorance, and they have no right whatsoever to do that. And very few of these people that make this decision have ever practiced medicine for more than 2 days and know very well that pain medicines have an extreme variability in people. And that's why the FDA does not limit the dose. They understand that everybody's different, and you may be having a bad week where you need twice as much medicine, but SAMHSA, the Substance Abuse Federal Agency, implies that if you do that, you're an addict. Because very few people understand that substance abuse disorder is different than addiction. And it is very different, and it is dishonest to try to mix the two. So
we have another call. Caller from area code 678. What is your name and what is your question?
Cedric.
Hello?
Yes.
Hi. What's your name and what's your question for Dr. Kline?
Cedric Burton.
Hi, Cedric.
Yeah. I was calling because I'm in pain management. And
can you shut off your radio behind you? I apologize.
Yes. Oh, I turned it out. I left out the room altogether.
Okay.
I'm in pain management, and they want to do surgery on my neck and my back. And I've been on these medications for a while now, for almost 6 or 7 years. I was trying to see what can I do to not fall into that category of seeking pain medicine and being categorized as an addict.
It's pretty much impossible, given the climate that we have today, because the more you try to defend yourself, the more you look like you're an addict. That's what we call catch-22. It's a bad situation. I think a lot of people who have chronic pain do not tell people that they take pain medicine, and I think that's a good idea, because you get the A stamped on your forehead. Only this time it's for addict, and there's really no answer, Cedric. You just have to say, I don't think I'm an addict. You put it softly. You don't say, I'm not an addict. You say, you know what? I've been thinking about this, and I don't believe I'm an addict. Can you tell me what an addict would be like? So you just kind of put it back on them, since they've accused you. You say, well, okay, I'm having trouble with that definition. Can you help me understand how I'm an addict? I heard they run around the streets stealing and stuff, because they've got extreme seeking behaviors. But I don't have that. I don't have extreme seeking. So isn't that the definition of addiction? The problem is when you get into it with these zealots, they just don't want to argue with you anyway, and it'll start becoming insulting even more. Then you can, just say, well, I didn't start this discussion to be insulted by you. So maybe we should end it and get up and leave.
But the problem with that, though, is a lot of people, especially if you live in the country, they don't have a lot of options of where they can go. So what would somebody do that doesn't have a lot of options or that has to deal with that doctor?
Well, you play Russian roulette, but you can file a complaint with the Board of Registration in Medicine, and your main complaint should be that you were undertreated for your disease. I think that's a good way to put it. You're undertreated. Now, the doctor can retaliate, but you know what? When the doctor gets the letter from the Board of Registration, they tend to treat you with more respect. So people are afraid to turn their doctors into the Board of Registration, but I think that's one of the safer things to do. You have to evaluate the odds yourself. There are some people that will try to dump you, but if a doctor discharges you from the practice because you filed a complaint, you can go back and file another complaint that the doctor ended your care because you complained. Again, it's a risk you have to take. But if you're being screwed, you have to decide.
Yeah. Thank you, Cedric, for calling in. Appreciate it.
Excuse me.
We had a few more questions because I know there's a few new people listening in tonight. Somebody wanted to know what the definitions were of addiction and dependency and the differences in that, because I think some new people just don't understand that. They think it's the same, but it's not.
Well, the best thing is to start with the definition of addiction. Addiction is extreme seeking of substance with no regard for consequences. So if a person is told that they're dependent, you can say, well, that doesn't sound like it's fitting the addiction definition, because I'm not intensely seeking, and nor am I doing so without regard for consequences. So you must be talking about something else, doctor. Now, the best word for dependence is wearing off.
Like, what do you mean wearing off? Hello? Dr. Kline? Okay. Well, I'm not sure where he went. But it's almost time to wrap up here anyway, so I'm going to go ahead and do that. I just wanted to thank our audience for taking some time out of your evening to join us here. And I also wanted to update you, upcoming guests, January 22nd, we're going to have Dr. Josh Bloom. January 23rd, we'll have guest Claudia Morandi from Don't Punish Pain Rally. And then January 29th is the National Don't Punish Pain Rally. Dr. Kline and I will be at the Raleigh, North Carolina rally live on air with the Doctor's Corner. So make sure to stop by and say hello to us and ask a question on air. I'm Janelle Elgaway with Dr. Kline signing off until next Tuesday. Have a great night, everyone.
This has been The Doctor's Corner with Dr. Kline and Janelle Elgaway. Copyright 2018. All rights reserved.